Hello, I'm Dr. Gerald Chodak, and this is Controversies in Urology. This week I want to talk about the new American Cancer Society guidelines on screening for prostate cancer, something that is likely to engender a lot of controversy between doctors and patients. The recommendation is that patients should be fully informed of the uncertainties, the risks, the potential harms, the potential benefits of screening before screening takes place. If they're going to get screened after getting that fully informed decision, then it should take place starting at age 50, unless there's a family history or if men are African American, at which point it starts earlier. They also recommend that for men whose life expectancy is 10 years or less, the harms outweigh the benefits and screening should not be offered, even though we know that throughout the United States, a very large percentage of men are getting screened through VA centers when they are 80 years and older. They also made the recommendation that if your PSA is done and it's under 2.5, then you only need a test every other year. And if your PSA is greater than 4, that is a reasonable place to consider a biopsy. For those with a PSA between 2.5 and 4, the decision should be individualized. They fully recognize that there is no PSA that guarantees the absence of prostate cancer. So this evidence-based recommendation differs from recommendations by the American Urological Association and the National Cancer Cooperative Network, both which have gotten considerable publicity for their recommendations. So what do we do with these different guidelines? Who do you follow? For the internists and family practitioners, are they better off following the American Cancer Society guidelines? And for the urologists, should they follow the Urology Society recommendations? I must admit that of the recommendations that are out there, this is the most evidence-based approach. And although there is still uncertainty about the extreme extent of benefit that we may see with screening and the potential for a lot of overtreatment, those results may improve with time as we see fewer men need to be treated in order to prevent one death. The committee also recognizes that we need more research on a better test, and we need research on finding ways to determine which men who have prostate cancer don't need immediate treatment because their cancer is not life-threatening. So there are important aspects here, but I do believe that this represents the most scientific approach to this problem. It doesn't say don't screen, but it does say don't screen without having that informed decision, and the Cancer Society is going to provide aids to assist in that. Now that does create some problems. For example, where is an internist going to have the 10, 15, or 20 minutes that it takes to do this fully informed decision process? Who's going to pay for that doctor's time? Will insurance companies look at this new guideline and say, well, we shouldn't be covering a routine PSA test because they're saying something else has to take place first, and a lot of men that are getting screened, something that does have to get further discussed. But I think for the moment, the issue is not that men shouldn't be screened, but they shouldn't be screened without first being fully informed of all the things that I talked about earlier. I think this is an important document, one that was well studied and well discussed, and that in the end, it may represent the best way to go for the time being until new information appears. I look forward to your comments.